record the meeting. And today, Pawan, roll the slides. Today, we are going to have a very practical aspect from very practical people from all around the country. This is the 56th edition. I welcome you, all of you, to this edition. Next slide, please. Let me welcome Professor Dr. Tufan Pati, sir. He's from Cuttack. Sir, if you are able to unmute yourself, kindly take over the proceedings. We are not yet able to hear you, sir. No, sir. Sir, ऑडियो जैक हटाकर डायरेक्ट फोन से बोलिए. Sir, your voice is not coming. Proceed to the next slides. I welcome my good friend, Professor Amritji Patjoshi.
Next slide.
Next slide, please.
And I welcome Muhammad Alim Siddiqui.
Yeah, thank you. Next slide, please. So let me introduce the chairpersons for today. They will take over the session and then we'll proceed. Dr. Rajesh Nagpal. He's from New Delhi. Everyone knows him, but for the courtesy of introduction, we'll introduce him. He did his MD from Chandigarh. He is partner of Sarvam Neuropsychiatric Center at Kalka and Jaipur. He is trustee of Deva Foundation and Anvita, the women's rehab team. He is chairman, section on developing nations, WPA, director of Behavior and Neuroscience Academy of India, director and professor, Institute of International Organizational Psychological Medicine, steering committee member, North Indian Bioethics Unit of Asia Pacific Bioethics Network of the UNESCO Chair, assistant secretary general, Indian Global Psychiatric Initiative, past president, Indian Association of Private Psychiatry, past president, IABP, and past president of Society for Bipolar Disorders. Next chairperson, please. Our very own Dr. Venu Gopal Jhawar. He is a senior consultant of psychiatry and director of Deva Institute of Healthcare and Research. Also gives voluntary service to Ram Krishna Mission Home, Varanasi, involved in various research projects, more than 50 clinical trials in various indications. He has been treasurer of Society of Bipolar Disorders in India. He is president-elect of IABP, board of director, International Psychogeriatric Association, chairman of Indian Association of Biological Psychiatry, Indian Association of Geriatric Mental Health, IPA board member, board of directors from 2012 to 16, director of Deva Institute, managing trustee of Deva Foundation, partner Sarvam Global Healthcare. So both the chairpersons are apt for the today's topic. Sir, the session is over to you, to the chairpersons. Please take over and proceed ahead.
So we have two interesting speakers, Dr. Chandrasekhar and Dr. G. Prasad Rao. Both of them represent very interesting facets of development of private sector in India. Dr. Chandra Prakash is known among his colleagues as Chandu, and very good strategist, an excellent clinician, and very famous for delivering homilies. He can get the distilled of private practice in a few words and convey it very simply and honestly. Dr. G. Prasad Rao is a star of Indian psychiatry.
We have a seat. Pawan, please put.
Yeah, I'll just.
Sir, let Pawan share the slides.
Okay, I'll stop sharing first.
Pawan, the slide of the speakers.
So, as I said, he's the founder, director, and current MD of Asha Hospital. He is the main strategist of Asha Hospital today. He's done his MD from NIMHANS. He's an ex-faculty at the Institute of Mental Health and Osmania Medical College. He's a teacher for DNV since 2006. He's a consultant to various corporate hospitals in Hyderabad. Besides all this, he has a very incisive knowledge about the Mental Health Care Act 2017 and before. He has led many debates in the country on policy issues or regulatory issues, and he is responsible for Asha Hospital being an NAB accredited hospital offering DNB courses in psychiatry and PDA program in child psychiatry. The next speaker is Dr. G. Prasad Rao. Next slide, please. Dr. G. Prasad Rao, besides being my elder brother, was the president of the Indian Psychiatric Society. Very erudite, excellent clinician. He has donned many hats, in fact, simultaneously. Nobody that has ever done that with as much aplomb as Dr. G. Prasad Rao. Deputy Editor of Indian Journal of Psychiatry, President IAGM, President IAPP, President Society for Bipolar Disorders, President IABP, and President-elect of AFPA. We have a very formidable panel. Can you stop sharing now and I'll share my screen? So as I said that the topic is changing practice in private psychiatry, and the second topic taken on G. Prasad experience in group practice, specific reference to Asha. Now, how does one? So I have a couple of questions for the two speakers. One of the first statements I am making is that private practice needs to be outcome oriented and not treatment oriented. I say that with a lot of responsibility. And the question that I have for Dr. Chandra Prakash or Dr. Chandrasekhar, I call him a Chandu, how does one address mental health equity in private practice? Remember, in the Indian context, mental equity becomes extremely important because not only of the caste division, the socioeconomic problems, but other problems inherent in a large developing country like ours. The second question for Chandu is, how does one address the perpetual lie that mental health care is a right of every citizen and it is free? Mental health care as a right is an aspirational aspect of MHC 2017. It is free is a complete lie. Somebody somewhere is paying. And the last question that I have for him, based on his formative experiences, seeing large number of patients at minimal cost versus detailed workup for a few patients at prohibitive cost, does it change the outcome? Remember, as practitioners, our interest has to be essentially on outcome. Nothing else will excite us more than a good outcome. Challenges and opportunities, I am throwing open the field wide open for Dr. Chandu. The post or intra-COVID tsunami of mentally ill we expected to happen has been busted wide open. It's no longer there. It's been proven by evidence-based studies, especially from West Germany, which has come in. Implementation of the MSc 2017 in letter and spirit will not occur without a parallel NGO movement. That's my statement. Insurance and sector and corporate sector is not yet interested. Regulatory authorities' strategy of ignoring the regulatory dictum of same norms for private and public sector is deliberate. And now I wish to shift focus to Dr. G. Prasad Rao, the formidable star performer of Asha, who leads by his own work. Sir, what are the terms of collaboration, equal or skewed equity in Asha? Is there a high table for high performers, a low table for low performers? How does one carry along the tail, the low revenue performers, in a group practice in Asha? Clinical outcome audit comparison of solo and group practice. Many of the star practices in Asha, like Dr. G. Prasad Rao, Dr. M.S. Reddy and others, Dr. Chandra Prakash, Dr. Chandrasekhar, also do solo practice. How much of the net revenue pool is plowed back into capex? And last philosophical question, with some reminiscences, was Asha a journey of serendipity or a Chanakya-like strategy? I invite the first speaker, Dr. Chandru, to start. Dr. Jawar will then take over at the end of the session.
Thank you, Rajesh. And all my friends, a very good evening. In fact, it's a pleasure for me to share some of my thoughts about what is happening in Asha. Not only that, how we went through this journey and what is the status now? As everyone knows, private practice has gone, the delivery of mental health care, I wouldn't say private practice alone, but the delivery of mental health care has gone several changes during the last few decades, at least since the time I came into the field nearly 40 years ago. Today's context is basically what we are trying to discuss about whether this group practice is a viable sort of a strategy, first of all. Then, actually, if you look at the future of clinical practice in psychiatry, I think some psychiatrists in future may still retain their single, what we can call as a cottage industry sort of a practice of psychiatry, left to their own clinics in their own fashion. Ultimately, it is the right of every practitioner to charter his own course over a period of time. But this sort of an independent practice is going to slowly disappear in the next few, probably 10, 15 years, in my opinion. And more so, it will be public, non-profit, or a private system which is going to take over. The four essential components of any private practice or any healthcare setup is the affordability, the cost of your service, the affordability, that is the patient satisfaction, accessibility of care, how accessible you are, and the ease of obtaining your services, and accountability, ensuring the quality outcomes. If these four things, if a practitioner is not going to assure to his patients, take it from me, that practice is never going to flourish. To realize these four objectives, probably an individual type of practice is not going to be the answer. We have to definitely go into what we call as a group practice in the long run. See, what happens in a group practice and why I really thought of it a few years ago is that if you look at the delivery of mental health care services in our country, basically the government services are usually not up to the mark. Let me be very blunt, because I'm a private practitioner, I don't need to mince my words. Basically, the government service sector, as far as the mental health care is concerned, is appalling. The second thing is the private sector is much more accountable. We know that 70% of our health care is out-of-pocket expenditure from the patients, and that is nothing different even in mental health care. As Rajesh was putting across, no health service is free. Even if you are going to a government hospital, the amount which the individual is supposed to pay is paid by the government in the form of salaries, in the form of creating the infrastructure, in the form of distributing the drugs. It is not free. It is free as far as the individual is concerned, but it is not free within the system. So there is nothing like a free service here. Now, what has happened in the last few years that made me at least think of a hospital-based psychiatric delivery system in a group setup. Somewhere along the line, probably we psychiatrists in India has totally forgotten hospital-based psychiatry. We went on campaigning in the late 80s and early 90s. In fact, I still remember there was a conclave or conference of the various superintendents of mental hospitals. I think it was somewhere in 88, 86, 87 in Ranchi, where all the superintendents of the hospitals across the country, there are 45 mental hospitals, and all of them decided that there are going to be no more hospitals in the country. Do you mean to say as the population increases, we don't require more psychiatric hospitals? I didn't understand the logic even at the time. That was the time I thought, when so much of service is needed, what is this, the policy concept of we don't want psychiatric hospitals? I mean, this appeared to me very, very illogical thing. We need to move ahead along with developments in the scientific field. And if the developments are not translated into the patient's care, I think we haven't done anything at all. And how do we translate that into the patient care is the essence of a group practice. The reason is no single psychiatrist. If I see a case of schizophrenia or a case of bipolar disorder or any other case of a serious mental illness, I need to provide a spectrum of services. It is not enough for me sitting in my clinic to just prescribe a couple of psychotropic drugs and say my treatment is fantastic. This individual needs, if at all, we have to implement all the therapeutic programs which we learned as students, which we even continue to learn even now. If we have to really implement those things, a single person's effort is never enough. So you have to create a system wherein this individual's needs are taken care of, starting from the acute care to the long-term care, to rehabilitation, to psychoeducation, to psychotherapy, to various other treatment strategies which are probably there in the textbooks or in the research. If you want to implement it, you cannot do it all alone. You need to have your colleagues along with you who share this responsibility, who share this vision. So ultimately, another thing which I particularly really worried about even the younger psychiatrists is that people are moving away from practicing serious psychiatry. They're very comfortable saying that I see people with adjustment problems. I see people with marital issues. I see people with minor anxieties and depressions. I do psychotherapies. I do X, Y, Z.
Okay.
And they appear to be very happy and contented with that, which I think is not really the issue. If we train our youngsters only in managing such things, who is going to take care of the serious mental illnesses? After all, as psychiatrists, we are trained to do that. If I don't do psychotherapy, there is someone else who is qualified, a psychologist, a social worker, a therapist, someone else qualified to do that. But if I don't take care of my schizophrenic patients, my bipolar patients, my seriously ill mental patients, then who is going to take care of them? That is one of the policy deficits which I find in our mental health care system. And the second thing, over the years, we have neglected the legislation. I think the less said, the better. And as you neglect the legislations, it's almost equivalent to neglecting the policies of mental health care in India, and that leads us nowhere. So at least in private setup, what I thought was a delivery of mental health care can be wholesome. To give a wholesome mental health care, I think we need the collaboration. It is a collaborative practice. Basically, the concept of group practice itself needs to be a collaborative care. And what we at least do is an individual growth along with institutional growth. That has been my policy since the beginning of establishment of Asha Hospital. The individual growth need not be compensated against the institutional growth. Both can occur simultaneously. Both can go on simultaneously. As I said already, the collaborative care involving other professionals. As I said, you have to involve a group of other professionals if you have to establish collaborative care models in the collegiate practice. The essential part of it is here a leadership which is responsible, a leadership which takes the responsibility of their actions in the group. If you do not have such leadership, it's very difficult to really carry on a collaborative group practice. The second thing is the partnerships with similar sort of similar thinking people is again an essential component of group practice. What happens in a group, in a such sort of a situation is, what I always say, you come up with an innovative idea. That innovative idea can be mine, it can be my colleagues, it can be my junior psychiatrist, anyone. Come with an innovative idea, put that innovative idea into practice as a pilot basis. Once you put that as a pilot basis, if you are successful, then you can scale it up. A small example I will give, which we started. Like, I think Rajesh will also remember 2 years back or 3 years back ago, I think, in a Shark Tank contest in the IAPP conference, I got an award, which was basically, the concept was that I create a high dependency medical emergency units in a psychiatric hospital and expand this over a period of time. I didn't leave that idea just because for that award's sake. I started it in Asha about 3 years back, a HDU, high dependency medical unit. Otherwise, where will my patients who have high mental health needs and high physical health needs go? None of the corporate hospitals accept them because they are mentally unstable and cannot be managed. None of the psychiatrists accept them because they are so physically morbid that it's very difficult to manage them in a psychiatric setup. Then where will they go? What is the answer? So unless I have an HTU in a psychiatric hospital, it is not going to give me the satisfaction. So we started it on a pilot basis. And today I'm happy to say that it is one of the key areas where we are very much satisfied. And God forbid, because of the COVID, we had to manage several physically ill patients in the last couple of years. And this HTU came in to picture very handy for us. So similar sort of thing, any innovative idea like specialty clinics, I think in future, I don't think people are going to really accept if a single psychiatrist says that I can treat everything on the earth, starting from anxieties to schizophrenias to bipolar disorder to psychosexual dysfunctions, whatnot. We see, I think some of us see fresh graduates coming out of the institute printing on his prescription pad that he can treat every damn disorder in psychiatry. This is not going to be the future. If I am a specialist in a bipolar disorder, I will try to use my skills to treat as many bipolars as possible. If I'm a specialist in geriatric psychiatry, I try to focus my attention on as many geriatric problems as possible. And this specialty clinics concept is going to take off. Believe me, this is going to be the future of practice in the next decade or more, or so. So right now, the concept of private practice in psychiatry has to be a group-oriented practice, group practice, a collegiate practice, specialty-oriented clinic practice. So inside a bigger group, you can always have different specialty clinics. Each one of the group, each member of the group can specialize in a particular area of interest. That is what is happening in Asha. Each one of us take up, depending upon our interest, whatever we want to do, and then see what best we can do in that area. There need not be any conflict. There need not be any conflict in revenue sharing. There need not be any conflict in one's own development. The simple principle is that you can earn depending upon your ability. That is another concept. The group practice does not mean that one of the group members sits idle and gets the money because the group is thriving well. No, that is not the concept at all. If you have to be financially more, I would say, earn more, you have to work more. You have to show your skills more to get more revenue for yourself. And these are some of the concepts with which we started. And I think the success of, I will definitely now, after 2 decades, I can proudly announce that Asha's experiment has been successful. Successful because 2 reasons. In the last 2 decades, no one who started as a group has left, saying that I am dissatisfied with this system. That itself is a quality indicator in my opinion. No one said, I'm sorry, our group is not going to really gel well. No, that complaint did not come at all. On the other hand, we were able to recruit more number of people into the system. That itself is again a successful attempt in my opinion. So what I'm trying to say now or conveying now may not be of much value or interest to very senior members. But if there are people who are listening to this, who have at least 20 years, 30 years of practice ahead, probably they should really give a thinking in their own localities how to really start a group initiative. If you have to deliver the mental health, total mental health. See, as I said, the government's response, I don't think it is going to dramatically change the next few years. You may talk about any programs. All of us know the so-called mental health, national mental health program, after 4 decades, how many districts are covered and how efficient they are? It's for us to see there. If a program after 40 years is not successful, do you think call it as a good program? No, not at all. So don't depend upon the government programs. 70% of the care in delivery of mental health care in India is in the private sector. The private sector has to rise to the occasion. And the other thing is, I think there needs to be a lot of course correction in the psychiatry, the way we look at psychiatry, the way we practice psychiatry. In fact, the way we teach psychiatry in India, there needs to be a real course correction. What is that course correction? Probably the time will not be enough for me to really elaborate, but at the same time, who is going to do this course correction? Is it going to be the private psychiatry? Is it going to be the other psychiatrists sitting in the institutes, psychiatrists sitting and policy making bodies? I don't know, because as of today, the policy making itself, I think, there are a lot of loopholes. The National Mental Health Policy very proudly announces that there has to be good public-private participation. How much of public-private participation the government is really encouraging? I don't think there is very much of encouragement in that area at all. So, ladies and gentlemen, basically, let me again emphasize that it is not a very difficult proposition to run a group practice in psychiatry. It's not at all a difficult proposition. But one has to have the will and the vision, how to take the whole thing forward. I think with this, I end my talk, and thank you very much for giving me the opportunity.
Thank you so much, sir. Wonderful, wonderful listening to you, sir.
Am I audible now, Alim?
Yes, sir. Welcome back. Please take over.
I have been constantly listening.
Yeah.
Maybe this system had to be restarted. I restarted the laptop.
Can you invite Prasad Rao, sir?
So my dear friend, Dr. Prasad Rao, please come over and deliberate us.
Dear friends, it's a lovely opportunity for us. First of all, I'm very happy for giving us the opportunity. Greetings from Asha, Tufan, Amrut, and Alim. Thank you for inviting the Asha family. It's not moving, my slides are not moving. Are my slides visible?
It's visible, sir.
Yes.
Okay. It's not moving.
Yes, sir.
It's not moving. Yeah, got it. Yeah. So I start with thanking the sponsors of today's evening. And what I'm really going to share are two important things. Chandu has really laid down the fundamentals. What he talked is actually what we experienced in group psychiatric practice for 3 decades in Asha experience. And today, in my brief presentation, I'm going to cover the history and the milestones And as you see in this picture here in my slide, it was never always going north. It was some ups and downs we did face in terms of balancing, but each one of us stood the ground. Thank you, Tufan, Amrut, and
Sir,
Nadeem.
sir, can you please raise the audio? It's not, you're not very audible, sir.
Now is it okay? Is it okay?
Yes, sir, better.
Better, okay. Thank you. I will start with this quote of Neil Armstrong way back in 1969. And what he said is, one of the smallest steps a man takes, it leads to giant leap for the mankind. And I'm quoting this with a simple policy in terms of group practice in psychiatry as an example. Unilaterally cutting costs won't eliminate the inefficiency or unnecessary procedures and avoidable burdens in the system. But we work together with fresh thinking and strategically smarter spending, and we can recast into more and humane, efficient mental health care system. That has been probably one of the central and cornerstone of our practice. The group practice in psychiatry in private setting was a novel concept when we started. I'm talking in 1991, actually 90s. And remember at that time, each one of us at that time across the country were looking for their own practice individually. Where there were only few psychiatrists in Hyderabad. What used to happen, we joined in a very small way, four of us. Myself, Dr. Chandrasekhar, Dr. Jagannath, and Dr. K. Krishnamurthy. And Dr. K. Krishnamurthy at that time was the superintendent of IMH. Dr. Chandrasekhar just came out of the government service a few years back, 2-3 years to be more precise. In 87, there was a ban in psychiatry, a basic ban in medical practice. He came out. I started my own practice in 1987, and Jagannath came much later. So in 1991, it was really a novel concept. And even today, as you would see, most psychiatrists are still looking for how to do a group practice. And I'm going to tell our story. I think the I'm just summarizing in a single slide how a group practice should go. Essentially, it's a friendly relationship between same peers. I think Chandu has did cover about some important issues. Each one of us are strong on some areas. We need to have a camaraderie. We need to have an enthusiasm to grow. We need to have a different approaches, a critical eye in the group, a good leadership within the group. A leadership emerges as we grow, and ability to tolerate. It's like a family, maybe a joint family of yesteryears, paternalizing at times, but leader with vision is always there in the joint family. So good psychiatric group practice started for us like that. I'll tell you my brief stories from Asha. The first experiment or experience is Chandu and three of us we started, four psychiatrists along with psychiatric social worker, one anesthetist, a psychiatric nursing home. We worked for a year and plus. Unfortunately, we had a problem with the owner of the building who rented us. But what our experience is, within 2 months, our beds are full. And we are always looking for whom to discharge than whom to admit. Mind you, there were three psychiatrists. Jagannath just started practice. I was there in practice for hardly 2 years. And Chandu was there in practice for maybe, I think, less than a decade, but around 70 or 80 years. And of course, Dr. K. Krishnamurthy did have practice. But most important, we started, it was surprising because patients start coming to emergency services, they would get admitted. The flow went on very well in the Mamata Hospital. That was our first name of the group practice. But unfortunately, we had problem with our landowners. That was the time the birth origin concept of Asha Hospital started. Though it is little later, but the seed was in 91, 92. The group concept, sharing the burden, sharing the love of each other's energies in private space where we planned all inpatient services and all OP. You will be surprised. Those days we only kept 20,000 rupees each as the initial investment for four of us. And as I told you, the hospital run really successful. And at the end of year and a half, when we have to close the first hospital, Mamta Hospital, because not because of our cohesion, but because of the social reasons, because the landowner had a legal problem with the government and that hospital was locked by the government, not by us anyway. So when we closed the new project for important jump, each one did carry a big bunch of money back. I don't want to tell you how much we carried back, but it was definitely much more than 20,000 rupees. Then the real birth of concept of Asha started. Now from the four in the past, we have now come to six, starting at, and this concept of Asha Hospital, you will be surprised, we had at least 20 to 30 meetings starting in the evening after our practices those days, because we were practicing at that time. It would start somewhere around 7:30 to 8, go on till the next day, and we would probably have spiritual journey as well, the mircha bhajis and hot discussions. I brought mircha bhajis because it used to give the heat, and we brainstorming. We agreed to have the basic thing we agreed is a vision, the pathway, and periodic assessment. And I'm going to show you in the next few slides how our vision actually shaped. Asha Woodland was the next phase of development. Woodland Hospital was then a 70-bed hospital which was not running at all. So we went and took one part of the hospital. At that time, Dr. Raghuram Reddy, who just was retiring from the superintendent of IMH, joined us. Chandrasekhar, me, the new friends are MS Reddy, along with Om Prakash, our anesthetist. That was it. Our concept was we had a 35-bed hospital, but we also had a scope of another 35 rooms, which are considered, so 70 beds. Practically, it was practically a mini hospital for us, and we really clicked. Now this is the where our ideas of Asha Hospital started, and I'll show you in the next two slides that we worked, Dr. M.S. Reddy and Venkatramana, and at that time, even in Asha Woodlands, where we were there for 2 years, we had this concept to look for a bigger space because we know this is not our space. That's the time when Asha Hospital in 1994, Banjara Hills was opened. Ladies and gentlemen, we scotched for a space, we scotched for a builder, and we built the hospital to our ideas. And Chandrasekhar and all of us, as we said, the 30, 40 meetings which we had is to build up. And this is the first Asha hospital, which we opened in 1994 or 93, 94, I would say. As you see here, there are three blocks all connected, and we had roughly around 70 to 75 beds. And we built with our requirements in mind. It was opened by none other than Professor Raghuram Reddy. You can find our MS Reddy there. And Professor M.M. Khan, who was probably the only successful psychiatrist running a nursing home of 20 beds at that time. We asked him to open. There was only one more psychiatric hospital of MVR Sharma at that time in private sector. But our concept, Dr. M.M. Khan and we used to have a very long association. He used to sometimes joke, how are you going to join? How are you going to run? How is it going? But he used to give a lot of inputs. And Professor Niranjan, the senior most clinical psychologist, formed part of our clinical psychology team at that time. So we had, right in the beginning, a multi-speciality. And Asha Hospital, Banjara Hills, between 1994 to almost 2014, had a very great run. We never had problems. Soon, all the psychiatrists in the country, and in the country means in the South Zone part, started knowing about Asha Hospital. Our futuristic goals, but we always met once in 10 days to 15 days. We always had meetings. How to go forward, how to improve the services. From the initial 6, we became 9 directors, and that 9 core directors continue to today and form the part of the original 1991 Asha project. Our logo was made. Our caring minds is our bygone word, and affordable mental health care was our services. We always felt that service to the patients, develop multi-specialty services, satellite services we developed over a period of time. Surrounding 4 districts, some of us used to go there. Even to this day, Chandu goes to Mahbub Nagar once in Wednesday. Dr. Jagannath goes to PHC and other places across. each one of us contributed, as Chedu has said right now before, that each one have our own strengths and we use that strengths. Extension services started. We always had 5-year target plans. So each 5 years targets, we almost met much before the 5-year plan and we went ahead. So much so, by 2004-5, our beds are always full. So the need for a rehabilitation center started. And we started planning and we built a rehabilitation center. The reason for rehabilitation is we felt an acute need for our chronic mental ill patient, at least for a short-term rehabilitation program, which we thought would be for three months at least, maximum 6 months. Most of my last more than 3 months. The main thrust in our group practice is uniformity in care and like-mindedness. Consistency. The care is very consistent. Division of responsibilities is well defined. Some of us would look after, say, pharmacy. Some would look after a research wing. Some would look about the outpatient care. Some would look about the overall administration. We always had MD for 2 years, so MD would keep changing. Of course, right now everything is thrust on Chandu. Right now he's our MD for the last 7 years because he's a man with a different vision. And affordable price has always been sharing the goodwill. And the one on the right, I want to stress, we never went for marketing. We never went for cut practice. We never went for easy money. We always identified that weaknesses of others should not be exploited by us. How to work in a good phase, and even to this date, most of our patients do have concessions at the end of the bill. That's what it is. We moved along in the last this is 3 decades now, and sooner what has happened is that 70 bed itself is getting full. The rehabilitation is also getting full. So we started building. Slowly but surely we moved forward. All psychiatrists in Hyderabad admitted in our hospital. We are very proud of it. All psychiatrists at that time, including Professor M.M. Khan. His difficult cases used to come to us. And soon the entire state and some from the Jones also got admitted in our hospital. We used to take proud. Whole India started recognizing Asha as a model. Few of them came from the country to look at the hospital. From Ahmedabad, Dr. Manyar is there. He came and visited our hospital for days, terribly impressed, but he started his own group practice system. In Hyderabad itself, people who worked with us, used to practice in our hospital, started Chetana as another center. So group practice as a seedling, we have probably pushed through and adopted both. Each, of course, would adapt to their local adaptations with a bit modifications. Our hospital, as we worked hard, is probably the first psychiatric hospital which has an NABH accreditation for a psychiatric hospital. So we always kept gold standard. There are a lot of milestones. I'll just go through very quickly, not taking your time, but it is a necessity for you to know the pictures. We built the current acute unit according to our needs, plans, because, as I told you, 70-bed hospital was getting full. And this hospital, and I'm going to show you the pictures to you very soon, was opened by the DGP of our times, the first DGP of Telangana, Mr. Anurag Sharma, IPS. And along with him, of course, all the senior psychiatrists came for the opening. Our satellite centers are run in Nizamabad, Mehboob Nagar, Tryon cities. Within our own cities, we had multiple clinics of Asha. One in Sainikpuri, one in Dilsukh Nagar. We adopted, as I said, PHC Narkoda. We started now social commitment to the society. We have done a free services for the PHC, prevention of suicide services, and student suicide prevention and farmer suicide has been our goals. In the last decade, we started the neuromodulation clinics, and we have done research as well, and biofeedback technique, and 2 RTMS units and 1 TDS unit. Our research actually won national awards for these 2 areas. Asha, the brand, is now well established. I don't need to shout from a rooftop, but suffice for us to say that we started from an acute psychiatric unit to other psychological problems as well. Golden Oak is a totally new concept. Geriatric services in about 3.5 to 4 acres land, where about 30 to 40 beds cottages, rooms are available. This is a center where we have trained. I'm going to show you snapshots of photos. There are multiple phases of Asha Hospital. The hospital currently has 6 bedded high dependency unit with the round the clock emergency services from 2017, as told by Chandu. This has really changed our own psychiatric practice. Previously, any patient who is critically ill, we have to shift in the night. An emergency doctor has to, and there were probably 1 or 2 deaths during the transit because we might have missed. But touch wood, last 4 years, nothing has happened because there was always an availability of services. A true ICU within a psychiatric hospital. We can boast that this is probably first psychiatric hospital which has an ICU within ourselves. Then, across, apart from the acute psychiatric, we have a lot of other issues which we need to tackle. We started academic programs in our center more than a decade and a half back. Probably one of the earliest centers to start DNB. And most of our DNB students across the world, 2 of them are in US, rest of them are currently across the country. Most of them won laurels. The 3 gold medals won by the best psychiatrist, which was launched in the year 2015, is from Asha Hospital. So I think our academic training is also sufficiently good. We also finished 3 batches of postdoctoral fellowship for child psychiatrists accredited to the 2 health universities. DNB is probably a part of the our work. Some of the DNBs have joined Asha Hospital. We have a lot of proud and pride to have them as the junior faculty. The 2 rehab centers. Initially, we started with 1 rehab centers. Now we thought, and I'm going to show you the snapshot. We have just done a Bhu Puja to start a women-specific rehabilitation center. Truly, at this point of time, there are 6 campuses. 1 for de-addiction center, about 30 bed, 1 for rehabilitation center, 1 for the geriatric center, 1 for the women rehabilitation center. A new center which we just started recently which I'm going to show is for the women and child center. We are now have young women psychiatrists, young team who are going to look for the perinatal psychiatry, issues of premarital counseling, postmarital counseling, and all the issues. And one more new concept we just started about this year is the Wellness and Positive Psychology Center, which is just shaping in spite of COVID. The drug development research in psychiatry. We are very proud. We have done at least 69 drug trials. We were audited by US FDA, myself 8 times, with no observations. And those who are in the drug research will know, no observation means they did not find any wrong findings in our research. Apart from that, we have multiple researchers published, and not only that, by our own faculty, the senior and junior faculty, we have already won 35 national awards in the 2 decades, and including 4 international awards. And we are significant leaders. Each one of us are significant leaders in the chosen specialty in psychiatry, both in IPS, World Psychiatric Association, World Federation of Biological Psychiatry, AFPA, etc., etc. The youngsters, the PGs and young psychiatrists, now I'm going to show you my young team. 35 published research in the last 10 years itself, and multiple book chapters. They have already won 15 awards for their research in this center. And what are we looking for the future leadership? And I'm going to close with a snapshot of photos. As already said, Asha now has nurtured the 2nd generation psychiatrists. A whole new 25 of them joined us as in the group practice as a joint holders, joined as partners, giving us energy, the new sparkle and the vision. And of course, the energy which we gives, they're being trained for the future leadership by the mentors, respective mentors. Well, this is the young brigade. And whom do you find in the center? It's me. I'm still young in the heart. I'm still 40 years old. These are all the young people who are going to be the future of Asha leadership. Asha, not only that, we have organized till this point of time about 15 national conferences, 2 international conferences, apart from regional and state conferences. ANSIPS 2015, every one of you would remember, is the ultimate success for us. We set a bar which is yet to be broken. We served for 4,500 people sitting, spiritual serving or the whiskey serving on the table. I think no ANSIPS has done that, apart from a lot of other things which we have done. Now I'm going to just close my presentation with the snapshots of the photos. This is the new Asha Hospital photo which you see here. This is the 100-bed unit, 6th-floor building, and you have all the specialities. I mean, these are all the list of people who are working right now. Then we have the specialty clinics, one after other. Asha Schizophrenia Clinic, led by me and my team. Asha Bipolar, as you know, MS Reddy and his team. Child and adolescent guidance run led by Dr. Gauri Devi and a whole lot of young psychiatrists, psychologists, speech therapists, and also, as you find in this, we have a rehabilitation person as well. We are going to serve, and this is a center which has the most comprehensive child psychiatric center. Some of this is building up. As you see, the new adolescent unit is there started. And the newest probably is the women wellness clinic. And as you can see in this, we are now looking for the perinatal psychiatric care, psychological issues related to fertility, psychiatric illnesses related to women, particularly trauma and stress related to women, PTSDs, the female psychosexual issues, eating disorders, and whatnot. Then we come to the most specific thing as we go about the psychology unit. We have probably the super specialty department in psychology. We have a lot of things which we are doing in psychotherapies. Our team is increasing by the day. We have roughly around 10 to 12 psychologists working with us. And mind you, the waiting time for a psychological testing is still 48 to 96 hours. So the Women Wellness Clinic, ably led by Sweta Reddy and Amulya Koneru, and we have a lot of people going on there. Last but not the least, this is the one which I want you to see each one. This is the acute medical unit which we just talked about. This is the team of, we have a very protocol for an emergency psychiatric care. Anybody coming to emergency will follow a particular protocol and they follow the admission, ably led by Jagannath and his team. And as you see, all of them are the young psychiatrists of our generation. And finally, coming to the rehabilitation services. This is the geriatric services, and this is our golden oak. As you see, Chandru, Nazmat Sakib, and we have a special trainee trained in geriatric psychiatry who is also assisting us. This is a snapshots of photos of the geriatric patients in the center. We have both outpatients and inpatient. And child and adolescent, we are actually adding a new group of people. This is the first AGRC or Asha Jyoti Rehabilitation Center, which can host up to 275 patients. And very next to it, these are the snapshots. What we have done is we have also kept solar energy on the top of the 3-floor building, as you can see here. So we are actually bio-energy saving. And of course, this is both group therapies and the activities in the AGRC. And there are a lot of games. Each times are separate for women and men, and each have different times to altogether, as you can see here. And finally, the Golden Oak and the Geriatric Center, a few ones which we keep doing all the time. This is from inside the geriatric picture. What is our future? As I said, women-specific rehabilitation center we are opening. Furthermore, satellite centers across this state we are having in this 5-year program, and also in the neighboring state of Andhra Pradesh. And of course, as I just said, myself, along with my lovely wife, and Jagannath and his wife, have just done the foundation puja about 2 months back. And we hope to finish this project in 9 months' time as a rapid pace. In conclusion, we could and continue to train to achieve our dream and expertise with the group practice. Not only that, our next generation of group practice people have joined us, 25 of them, and we dreamt big. We achieved many goals. Maybe we were frustrated sometimes, but always, in summary, our experience with Guru practice is so successful. We started with 4 people. Now we have 45 psychiatrists working together, with defining our space and working together. Thank you, gracias, dhanyavad, and ladies and gentlemen, because of the shortage of time, I have to rush through. Any questions for your clarifications to best of our ability, myself and Chandru will answer. Thank you very much.
Thank you, sir. Brilliant presentation. Thank you so much, sir. I think Venu sir is there. Is he here?
Yeah, I'm here. I'm here.
Sir. Your comments as a chairperson, please, sir. I think you have to visit some.
Professor Srinivas Murthy is raising his hands, please. And Gautam Saha is also raising hands.
So
Sir, we'll take them after the chairperson, sir.
Yes, yes.
Thank you,
Oh.
Dr. Chandrasekhar and Dr. Prasad Rao, for this excellent initiative. And I think what you have done with Asha is certainly a model worth replicating. And the most important thing which I like the most in Asha is it's basically a system of mental health care delivery. So what we all need to do is basically do a mental health care delivery system. And life is a learning curve. We keep on learning from each other. And that's I congratulate both of you again and the whole of the Asha team. And let's hope that most of us learn from you and your experiences so that we can provide better service to our fellows and our people in our country, and especially give a wide range of services across all the specialities in an inter and intra psychiatry. With these few words, I'll take leave, and I already informed the organizers that I have to leave at 9. So thank you once again for inviting me, and I appreciate this invitation. Thank you very much.
thank you so much, sir.
Thank you very much.
We have two hands being raised, so we'll take their.
Yeah, Murthy sir is there. Sir, please go ahead.
Okay, thank you very much. I was very much looking forward to listening to the presentation as I wrote to Prasad Rao this afternoon. And it has been a very good learning experience. I want to congratulate the group. And but I have 3 problems in this area. First one is this dichotomy of private sector, public sector. The strong statement made by Chandrasekhar, NMHP is a failure after 4 decades. Please stop making these statements. It doesn't do good to you. 2/3 of the population of India is on a food subsidy at this point of time in this country. No service will reach the ordinary man except from the public sector. Please don't talk about 5-star services as the solution to the things. 2 other aspects which I want to talk about is that about 10 years back, the Indian Association of Private Psychiatry honored me in Chandigarh. I raised the issue of public accountability, scrutiny, and ethics. If anyone is interested, I can send you the presentation I still have with me. Till today, nothing has happened. Unless we become accountable, particularly in the private sector, we will go down. Every day, I hear of misbehavior, misuse of the things in the private sector more than in the public sector. People talk about public sector being poor, but private sector being exploitative. Let me give you one example and stop with that. In Chandigarh, there is a psychiatrist who happens to be my student, charges 2,500 rupees per consultation. Couple of years back, I used to travel in an auto to help in a cancer hospital. One day, the auto fellow said, "Sir, you are going to the hospital. Are you a doctor?" I said, "I'm a doctor." "Sir, what type of doctor are you people?" "I work the whole day and earn about 300 to 500 rupees profit at the end of the day. I took yesterday my daughter to a doctor and he charged 300 rupees, didn't even spend 2 minutes." See, this is what is happening. I'm not saying one is better than the other. Please, let's recover. We are a poor country. We have to think of solutions both for the 5-star people as well as the Daba persons. And there, I think the private sector has not done very well. And I just want to leave you with that thought. But what you have achieved in terms of building up the things, it is for the public. It is for the general public. The rich person is as much a part of the public as the poor person. But let's not say that because I am giving everything in a silver plate, everyone will be able to see it in a silver plate. It won't happen in India, at least not in my lifetime. Thank you very much.
Thank you, sir. Can we
Thank you,
invite Dr. Gautam Saha, sir?
Yes, it was an excellent achievement, I think. As Dr. Asha Hospital and team, what they have done, I personally visited their place. Not only that, what I liked most, it is a comment sort of that there are so many psychiatrists are involved there, so many mental health professionals are involved there, as well as they are serving also so many people. Yes, I do agree that the private sector is not always can reach as the public sector can reach, but definitely they are serving also the people, those who can afford. It is very clear cut. It is not that somebody is admitting somewhere. It is happening definitely that admitting those who are get admission here, they know that what are the expenditure, how can they agree. But it is definitely important that at least treatment part is divided into two. One is quantity, how many people you can serve, and number two is the quality of treatment. But it is fact that quality of treatment, if you want to provide, that you have to give some money to them. But congratulations to the team, because you have done definitely well. I am really, I think it's a very inspiring to me also, Dr. Prasad Rao, and team, Dr. Chandrasekhar, Dr. Reddy, those who are full team, you have done, it is not that, you have done it very scientifically, distributed in different branches, and also the rehabilitation. What I want to know, the 2 or 3 things, how many staffs you have in their hospital? Number 1. Number, what is the cost? As sir said, what is the cost? And do you get any profit? I don't think, because you are developing now. If it is got profit, what is there? Because it is also important for the private psychiatrists. Is there any profit, or you are just doing all these things? But one thing, what sir said, I think there are some social activities from your organization should be there, which should be mentioned that in regular basis. Maybe you have satellite center, you are doing it professionally, but in some center, at least once in a month or once in the same places, that should be there. That will definitely, that you are also doing something for the society also in the free of cost, like thing, in a regular basis in some places. It will be really nice. It is my suggestion. I don't know if it's possible or not. Thank you very much.
Yes, sir. Thank you, Gautam, sir. Dr. Rajiv Gupta, sir, has also raised his hand. Sir, please unmute yourself.
Okay. Thank you, Chandrasekhar. Thank you, Prasad Rao. I think it was a great learning exercise for particularly people who are in private sector. See, there's always a place for a solo practice, but the solo practice will have all limitations of growth and doing multiple tasking. And the way the Asha Hospital has developed, when there was a conference in Hyderabad, myself and Sandeep Goyal from the airport directly went to the Asha Hospital to see the Asha Hospital and understand how it works. So I think it is a good model to follow. And the plus point is the kind of the multiple activities they are doing, which are next to impossible in a solo practice. The second point is in government sector also, things are improving. I have seen a couple of prescriptions from the multiple aims that come in Jodhpur, Bhubaneswar, other places. They're fantastic prescriptions. Computerized with all IDs, everything is there. The government sector is also improving, but I think it has all its limitations. But as the private sector is concerned, it's a private investment-oriented sector. The government says it is a medical industry. We never say. The medical professionals had never said we're part of the industry, but you see the government always says it is a part of the industry and they talk like industry. So it is investment-oriented sector, whether the land price is concerned, the salaries are concerned, the expansion is concerned. And you see, every hospital has suffered, whether it's psychiatric hospital, non-psychiatric hospital, during the COVID times. And none of the hospital has been compensated by any government. So in private sector, I think let us be very clear that we should not have any kind of a guilt and a confusion. It is for those people who can pay the service. The air traffic is for those who can pay for the air tickets. There are a lot of poor people who want to travel by air. They deserve to be traveled by air. They have a lot of emergencies, but the system doesn't allow. After somebody has to pay for a service. A patient goes to the AIMS or the PGI, he gets a free treatment. It's not a free treatment. Somebody is paying for that. So that cost doesn't look visible. In private sector, it is very visible. And fortunately today, the plus point is we have the services and we have a lot of people who can afford those services. Thank you so much.
Thank you, sir. Amrit, I think let us invite the comments from our speakers, both the speakers.
Bindu, you do respond for the total number of staff and the profitability?
A couple of my responses. Am I audible?
Yes, sir.
Yes, sir.
Couple of my responses. See, I'm not saying that the government sector, there is no service. What I meant to really mention is that the policies or the legislations which are meant to improve the mental health care in India ultimately falls on the government, about which the government has done very little. The simplest example, Mental Health Care Act 2017. None of the states, at least majority of the states haven't really even put the mental health review boards. I mean, the interest shown by the government sector in the delivery of mental health care in India is not up to the mark. That is what I meant to say. It is not that national mental health program is not good. It is the way it has been implemented, which is quite appalling. That was simply my observation. I'm not commenting about the program as such. There's one observation. The second thing someone was suggesting, asking this query, how many employees are there? The clinical team, which comprises of the psychiatrists, the intensive care unit, and the trainees put together, and the clinical psychologists, if you include, the total comes to about 65. If you look at the administrative nursing staff, it is as per the standards of the NABH, so the patient bed ratio. Roughly about there are 30 nurses. If you ask me about the administrative staff and the other staff members, totally there are about 180 staff members in the Asha hospital group serving the different places. So that is the staff ratio. The second thing is the question of profit. Of course, I can't show my sheets because of obvious reasons, but I would still tell the youngsters that it doesn't run in losses. The practice is always a group practice or anything, it doesn't run in losses. It is always profit making. Let me again reiterate that we are not doing charity service. It's basically free but affordable. Like I said, always affordable care. Our motto was affordable care. And if you can provide that affordable care to the person, naturally there will be more takers for that. So it is not a losing proposition. Definitely it is a situation wherein you make enough profits for yourself.
Thank you so much, sir. Sir, why did you say that solo services might not survive? And add-on question.
I'm not saying that it may not survive. What I meant to say was that solo services will gradually come down, because once you expand the number of services which needs to be catered to the individual patient, a solo practitioner may not be able to provide that, and patients will definitely drift other ways. Because the patients have become much more demanding now, and much more, they would look at the, on the net or somewhere and say, why are you not giving me this treatment? It says it is available. I mean, so tomorrow someone is going to, for example, a small example, it's very difficult for a solo practitioner to institute an RTMS. It is not that simple unless it's personally very rich. The average practitioner cannot afford to provide that facility. Or say, for example, ECT, you have to depend upon a team. hospital or somewhere else. Especially now if the mental health act says 2 psychiatrists have to certify if the patient requires an ECT and so many other things. You need to have the collaboration of some other persons. That is in that context, as that solo practice may slightly come down. It's not that it's going to disappear. Probably still that maybe it depends upon your style of practice. Suppose if I'm doing only say psychotherapies and some other non-pharmacological methods of treatment is my sole sort of a thing, still I can have a solo practice. Nothing bars from that.
Sir, can I add something?
Yeah.
So will it be like these small nursing homes, small family care units that have disappeared, and healthcare become very expensive, prohibitive, and that will add to the stigma associated with mental health if we really don't take care of solo practices?
No,
when you are in a group, suppose I, Aleem, X, Y, Z, psychotherapist, psychotic social worker are together.
Right.
And then we need to feed them also. So let me
Right.
be very honest when I'm talking here. So I need to give somebody who does not maybe need a therapy. I might prescribe RTMS to somebody who does not need it. Won't it make it, little?
Not necessarily.
I won't talk about little.
Unethical, you mean say?
No.
I don't tell it is unethical. Nothing is unethical. But then when we give somebody a choice that if you take RTMS, you will become better, or we give a choice. We don't force somebody. Sometimes we have to offer them things because we have that.
See, I don't think group practice automatically or a hospital-based practice automatically makes the things costlier. That I don't really agree with that concept because see, these practices can survive only if you attract clientele. If you are too exorbitant, your clientele is generally going to slowly come down. People will not. So I still stress on that principle of affordability, affordability, and accessibility for any practice. If you are able to somehow manage these three things, I don't think the practice is going to really come down at any time. I don't think it becomes unaffordable.
On this question, without doing unethical practice, will you be in losses? Will you not be in losses?
Will not be in losses. I don't think one has to be unethical to
both
get profits.
May I answer
you can be profitable also.
response? May I answer to both of your response, please? See,
Sure, sir.
our costings over the last 3 decades now has never was more than the average market costs. On the other hand, the patient and the relatives were more satisfied. In fact, each patient would get few more patients as a co-referrals. Not only that, they are used to coming, walking to the clinic. Costing is
Sir, audio is very low. How, sir?
Yeah. Cost now, am I audible now?
Better, sir.
Yeah. See, the costing was never an issue, and our charges have always been to on an average, whatever the market cost. It was definitely not more than, not largely deviant from that range. And one of the good things which Asha has earned over the years is that our concessions to the appropriate patients has always been there, and we also started a new social responsibility for a few deserving patients. We are actually paying through a trust grant for them. So these kind of things can be sorted out once a successful run. I want everyone in this group to understand, if you are delivering services, they will never be in losses. They might be here and there deviant. You are sticking to the.
Can I have a say?
Yes, please.
Rajesh, are you there? I have to take permission of Rajesh to speak. So I'm very sorry that in the first part I could not speak, but I have been listening to everything that was being told by Dr. Chandrasekhar and Dr. Prasad. I want to make my observations in this way. It is not a matter of contrasting private practice with government service. The prerogatives and situations are totally different. The government sector has got a big setting given to them free of cost. Free of cost because government does not calculate from. It has a big manpower given to them free of cost. And they have got many obligations in addition to treatment and allied services. So we cannot compare it with private practice. I have been always in praise for Asha hospitals combined group practice for this reason, because if a group of people can practice, it broadens the spectrum. And ultimately, Asha is a product as much as Dr. Tofanpati is a product as a practicing psychiatrist. It depends upon you how you position your product in the vicinity, in the community that you are going to cater to. It is totally in management terms is a matter of positioning, how you position. Dr. Gautam Shah, how he positions him, is there looking at the screen. And how Amrit positions, how Alim positions. There has been many experiments. I can tell about 2 experiments. I started in 1996. Group practice. We were 3 persons. It was running well, but it could not fail to attract others to join because of many reasons. Because at that point of time, group practice was quite, personal practice was quite good. Nobody wanted to be combined for a better open and more avenues of service were there. And when one of my partners expired by accident, it fizzled out. Another practice, maybe that Murthy is there. Another practice, a very good friend of mine with whom I have spent a lot of time in Nepal is Dr. Ali Hassan of Barampur. I had particularly requested him to be here because he told I have not made survey I won't change. I know him early 90s and late 80s. He had a big practice. People used to wait in his orchard below trees, cooking for themselves. And it gradually developed to a center with 5 or 6 psychiatrists and catering to many patients. They have got all facilities, clinical psychologists, psychiatrists, reach out clinics. So this is how you develop. And it is a personal decision, but group practice has got many advantages. And it has got some disadvantages because some of the persons involved in group practice, if they think that their personal positioning is going to be impaired by that, they cannot be good partners in a group practice. But group practice has many things that can be, there is some surrogate for you, just like a joint family and nuclear family. And still, all praise for Dr. Chandrasekhar and Dr. Prasad Rao. I had tried to invite all the people who are involved, and because I know I have felt the pang when our organization collapsed. Nobody came out to support. And when it became myself, it is myself single practice. Prasad Rao knows. When I posted 99 and 6, it was a total group practice. Sent for our occupancy rate was 150%. Not 10%. Always there are people in waiting. So I have seen both the sides. Individual practice has got, one can do everything in individual practice. One thing, the things you want to do in hospital, you go to everyone is giving a city near nursing home. You get that support. People are giving RTMS in another establishment. That is possible, but what is suitable for the person in that area, that is important. All the places are not Hyderabad. All the places are not Bhubaneswar. And in all the places, you cannot get so many of psychiatrists to join together. That is the bottleneck. And private practice by individuals has got its importance. Private practice in group has got many advantages. And disadvantage is personally depends on the members. But Asha is a good experiment and an inspiration. Kudos to both of you.
Dr. Gautam, thank you, Tofan sir. Dr. Gautam sir wants to add something. Gautam da, unmute yourself, please, sir.
Yeah, good. Thank you, Dr. Amrit. Dr. Tupanpati already said that I am also, it is not that the solo practice you cannot do so many things. This is actually depend on the mindset. Mindset is important because in my practice, I have seen that I have started in a small room. Now I am doing solo practice, but I have RTTMS, I have EEG, I have ECG, I have another child psychiatry unit, I have psychologist under the same roof. The thing is that it is the mindset if you want to develop your center, individual center, or if you want to do service in a quality service you want to provide, it can be. The thing is, if the patient can provide it, afford it or not. And number two, definitely I do agree, Dr. Prasad Rao, it is always, if it is in a group, if you do, in Bengali it is called Dashamile Kori Kaj Bhari Jiti Nahi Raj. I mean, if 10 people are doing the same thing, it is, but one thing is very important, that is whenever you go to a joint venture, this should be done by like-minded people. Otherwise, it will be in problem. But you have done fantastic, and I am also inspired definitely by today's talk by Dr. Prasad Rao and Dr. Chandrasekhar. Thank you so much.
A small comment. I think the other biggest advantage of a group practice is the personal life of the psychiatrist is definitely better. You have more time
Yes.
for yourself.
Yes.
You have
Yes.
more time for your family. You have more time for your relaxation. The individual psychiatrist in the group has got a better quality of, I would say, life. More relaxed.
Yes, sir. I think Dr. Maniyar sir and Shashira ma'am want to share their thoughts.
Yeah.
Maniyar.
Let me say, we have learned many things from Asha and we are much behind Asha. But probably we are the biggest group in Western India. At present, we are total 12 psychiatrists and almost 10 psychologists working together. We are 20. Earlier, we started with a small hospital which we rented. It was a 20-bedded hospital. Then it was a 30-bedded hospital rented. Unfortunately, what happened because of there are some municipal laws, the building was taken away, and then we had to hire a private nursing of two floors. And recently, we have our own building with a basement, ground floor, and 5 floors, total 7 floors, 50-bedded exclusive psychiatric hospital. Now, this psychiatric hospital is open for all psychiatrists. Any psychiatrist can admit. We have a 24-hour psychiatrist and a medical officer there. Same height, the emergency patients, emergency care is there. We have a 4-bedded hide care unit with a bedded wall so that patient cannot injure himself by banging head and all that. In our unit, we have general psychiatrist, one person, 2 persons are looking after de-addiction mainly. We have a child psychiatrist who is trained in UK in child psychiatry. We have a geriatric psychiatrist who has a degree of DM geriatric psychiatry from Lucknow after MD psychiatry. So only thing would be, it's a joint family. See, in my house, I've got my mother who is 90 years old, who is not doing anything, but still getting all the services. I am working, my son is working, and my grandson is 9 months old. Still, all are getting the advantages of the family income and all the family facilities. What about talking about the emergencies? See, just now when we were talking, I got a message from my hospital that one emergency patient has come. Now, if I am in a solo practice, I have to run for that. I have to leave this meeting and I have to run. No, someone is there. So there is someone who is on duty today, or means there is a 24-hour psychiatrist. And earlier we had no 24-hour psychiatrist, 24-hour medical officer there. Then we had a duty on a particular day. I am available on a particular day. Another person is available on that. So we have once a week we had a duty. So other 6 days you are free. Another thing about the MH, after implementation of MHCA 2017, it would be very difficult to practice psychiatry, particularly indoor psychiatry. You should have this much of staff and this much of, then for you to take this signature, and if there is an involuntary admission, then either 2 psychiatrists or 1 psychiatrist and 1 medical officer should sign, and all these problems would be solved in a group practice. The only thing would be it should be same-minded people. And probably we have an advantage. I am 67. My another was next senior colleague is 50, then another is 40, another is 30. And we have few of them were my students. Few of them were my students in another college. And all we are 5 directors at present, and other are partners to some extent, other are full-timers. But only thing would be, it should be a joint family system, and it should be flexible. Then only group practice can survive. And luckily, we are in group practice from last 14 years. And we are getting good number of references from Gujarat, Rajasthan, Maharashtra, Madhya Pradesh, and we are branding GIPS, Gujarat Institute of Psychological Sciences. Thank you for allowing me to speak. Thank you.
Thank you so much. Thank you so much.
Rajesh bhai, you'll have to send Asha 10% of your profit.
Now, can I share my views?
Yeah, ma'am.
So it was a very inspirational journey. Really, congratulations to Dr. Chandrasekhar and Dr. G. Prasad Rao, sir. But what I only wish it should have taken place about 15 years back, because I run a solo nursing home, which is 15-20 bedded, and I know how difficult it is. You're always on your toe. And just now, sir said that if there is an emergency, you have to rush. Plus, so with the new Mental Health Act, it is also important that if you have a group, then it is a safeguard. So definitely group practice is much better, because you can have better family life. You're more safeguarded. You have colleagues in your times of trouble. So it's really a very inspirational journey. And I hope people in Lucknow also take up this, especially Dr. Alim, to come forward. Because I feel that right now I'm 60 plus, and I wonder, after 5 years, what is going to happen to my hospital? But if there are people who are 50 or 45, then the thing is going to be carried on. So group practice is really good. Congratulations to Asha Hospital and the whole team.
Thank you so much, ma'am. Thank you so much, ma'am. Your advice is well taken. I will contact.
Alim, I think
in
there's a lot
Inla,
of
if Inla sir wants.
Indra, anything you want to tell? Indra, are you there, or your poster is there only? Huh?
He's there.
Yes, yeah, okay, please. You have got such a big institute to tell your good and bad experiences, your advice.
Yeah, thank you, Tofan and Alim and others. No, I think now we are having probably different kind of practices. Of course, solo practice and group practice, and something like ours, a family practice also. Nowadays, I think there are so many psychiatrists, their daughters or sons, and they are also upcoming psychiatrists. And in many places, we see now the family practice also. So it can be something like a group practice, maybe of not such a big size, but a small size of group practice. Of course, for every system, there will be plus and minus. It may be solo practice. There are some like, for example, family life may be good, personal space there. So every system has got its own merits and demerits. I think there may be some other group practice where there may not be as successful as Asha. Asha, of course, is very successful. There is no doubt about it. I think it all depends on the mutual understanding of the partners and the leadership, and also the time they have started. And all those things will add to the success of the practice. So probably somebody, if now they want to start a group practice in Hyderabad, I don't think it may be so easy for any other group now in Hyderabad to start and come to this level. So the time of their starting also has probably added to their big success, and the good leadership and the seniors, many seniors adding, and all these things will add. So definitely there is a scope for group practice, but at the same time, as Chandrasekhar has said, solo practice will continue forever. I don't think it will not have its own end. It will be there, and simultaneously the group practice and one side the family practice also will continue. What type of practice it is, ultimately it all depends on the affordability, as Chandu has said. the affordability, the quality of services, the patient satisfaction ultimately. That is the ultimate thing. So as long as our patients and clients are satisfied and we can give some affordable services, I think whether it is solo or group or any type of practice will be successful. So, every one of us should keep that in mind. The success will depend on the quality and the standards and the other factors which I have said. So once that is kept in mind, I think nobody should be unhappy, whether it is solo or group or family. I think everybody will be successful. I think probably there is a scope for group practice. And I think in India, apart from Asha and maybe few more group practices, I think it is not at very much prevalent. In my view, I think group practice may be very few places. I don't know why Chandu should answer why the group practice in Asha has become very successful, and in other places why it has not picked up, like in metros. Only few places it is there. Probably we have to analyze that also. Anyway, thank you for giving me this opportunity.
Thank you, sir. So my question to the speakers, as Inla sir has said, what have been the usual reasons of failure of group practice you might have come across? Tufan Pati sir mentioned something. So your model is successful, I think, because it had great visionary leaders. You were thinking ahead of your time, lot of persistence. So salutes to you. Why did other people fail?
We can't answer for the failures. One thing I'm sure about that: honesty, sincerity, dedication, and commitment to your patients. These four, between ourselves and colleagues, is a must for any group practice. See, and see, each one of us have our own strengths or weaknesses. Everyone knows. I mean, forget about being psychiatrists. Even as a human being, we know we have this weakness. But as a group, you should start gelling and accepting the other persons. In fact, one of the common question asked during our very early stage, 91, 92, what will happen if your patient goes to Chandrasekhar? I said, fine, it's good. See, I always believe that a troublesome patient of mine should go to my neighbor, not to me. But it's all a kind of a good thing which happens to each one of us. I think just because one patient, there are many instances over the last 3 decades where my patient is transferred to somebody and somebody's patient is transferred to me, and we all agreed on certain things in the beginning, and we would tell the patient. And so these are certain things which are common irritants. But there are few. I was seeing the chat box. A lot of questions are. Some are kind of a balance. Some are a bit pessimistic for a relationship. Here, I think the trustworthiness and starting a friendly bonding, and what Chandu and me, and Chandu's lecture actually has given me a good seeding, because he gave what we have done is not important. What he is foreseeing for the future, and for me, foreseeing the future is that the psychiatry practice is going to be definitely different from what this generation or the seniors of this meeting has observed. That's it. I think Chandu, if you want to say anything,
I would like to answer Alim. The reason is very simple. I can give that reason from my personal experience. All the people I am seeing in this gallery, which is just in my front, belong to big townships, big cities, where you can have in each city around 30, 40 psychiatrists, and you can at least coalesce with group with 5, 6, 7, 8 of them. But there are many places. I'm taking, there is a district. I know the name. I am giving a hypothetical name to it, Harirajpur. It has big population. There is a psychiatrist under DMSP who visits the district 3 days a month, 3 days a week. And there are people who go there and practice and come back. How do you expect there to be a group practice over there? And this is true of many places. What I am telling of is true of many places, and that was also true in my experience. When I started the group practice scheme, we are 2 psychiatrists, a medicine specialist who are done his MD from Maulana Azad Medical College, and a clinical psychologist. Not a small team in 1990s. But then in Odisha, there are totally 20 or 21 psychiatrists. 5 or 6 of them are having running practice. That means they are very much comfortable about their solo practice. The rest are in government, they're scattered all over the state. That is the scenario in many places. So where do you get persons? If you get 100 persons, you choose 10, and then you think whether you are having a bondage with them, that we can call them a family. But anyway, group practice is a big buffer in coming situations. It will be rewarding a lot. And one has to select very meticulously the partners. Otherwise, one can have a big hospital with employees. That is a different concept. Having a group practice like a family is ideal, but not so easy as told by Dr. Prasad Rao. Where Asha is now, maybe if any organization starts in Hyderabad, you'll be in that state after 20 years. Not that it is not possible. Asha has labored a lot. Asha had the advantage of less competition, but this new organization will have competition. But patients are many, scope is many, avenues are opening up. But main thing is dearth of people and unwillingness of the people to police. And many places in India, all the psychiatrists are clustered at one place. You can have only group practice at those places. That is the reality, basic reality. And anyway, any group practice has to survive and profit. Not philanthropy can be one of the objects, but none of the commercial ventures can survive on philanthropy. Philanthropy is different. So this is my take. I think I have answered a question, Adim.
Yes, sir. Thank you, sir. I think we can invite Chandrasekhar, sir.
I think one of the answers for your question regarding why it fails sometimes. See, the members of the group should definitely realize that every patient will not permanently stay with him. It is okay for my patient to shift to another psychiatrist. As it is, we know only we have follow-up is somewhere between 60 to 70%. All the 100 patients whom you have seen will not return back to you. If I am okay with the concept that I am going to lose a part of my clientele into the group or somewhere else and not get perturbed by that, the whole system will survive. Suppose if I start complaining today that I have seen this patient today, and next day I will ask Prasad, why did he come to you and you admitted him? That should not happen. I mean, this sort of a controversy is often erupt. People are so possessive about their own cases. That possessiveness about individual cases, if it is not there in the group, it's okay. Ultimately, the patient who has to get better. If I treat or Prasad Rao treats or MS Reddy treats or XYZ treats, is immaterial for me. If he comes to me, I will treat. If it doesn't come to me, it's fine. I mean, that attitude has to be built up in the group. Then it will be successful. Otherwise, you keep fighting with each other. Why did you take my case? Why did you admit my case? All these things will come up.
So you lose few to gain more.
Yes, exactly. You have to be prepared for that.
You have to be prepared for that.
It's a common thing, no? In psychiatry, none of, I can't claim that 100 patients whom I see are going to return back to me. If not to me, they will go somewhere, some other psychiatrist. It's as simple as that.
Amrit, you want to take any questions from the chat box?
No, there are a lot of, I want to talk about the financial aspects. I think we cannot discuss here. Maybe when we go on a visit to Asha Hospital, we will discuss how to go about it.
One session broadcast from Asha Hospital.
Yeah, we go to Hyderabad and discuss with them. I think we should. I think that's done for. Sir.
Amrit and Tufan, all three of you come and stay with us.
That's always an open invitation for Dr. Prasad Rao. Sir, thank you, sir. Tufan, sir, we should conclude this. Sir,
Yeah.
with a formal thank you. I think we all have. So thank you, Dr. Chandrasekhar, sir.
I should also acknowledge Ashok Reddy in this group. He is also part of Asha.
Thank you.
Yes.
So the topic was a little offbeat, but it was very, very pertinent. It was much required. Maybe even if you're a senior psychiatrist or a junior psychiatrist, tomorrow the juniors will come and ask how to start a group practice. I think we got
I have got a small question, if you allow, Amrit, for 1 minute.
Sir, you are the boss. I am just the clapper boy.
And we need a 2-letter answer from Prasad or Dr. Chandrasekhar. If anyone in this group, we had around 200 participants, that means they are very much interested, is inspired by the success of Prasad Rao and Chandrasekhar and need practical guidance. Are you prepared to provide to them?
Sure. Already I gave an example. Rajesh agreed. Rajesh Manyar agreed. We always actually, lot of people come and see us.
Dr. Manyar is an institution by himself.
But he has picked up everything from us. Rajesh bhai.
ऐसे छोड़ो जैसे हम जानते हैं वो he is the institution by himself.
मैं मजाक कर रहा हूँ. Rajesh bhai is a very close friend of mine. That's why I can play with him also. But he's a wonderful chap. Yeah.
Okay, now Amrit, please complete. Yeah.
It was wonderful listening to people who have been, who have taken a new concept, built it up, allowed it to grow, taken everybody along the way, charted new paths. Now they've come to the womb also, from geriatric to the womb. And maybe next time, in 5 years, we'll be having some space psychiatry or something that has been added to the Asha Hospital's arsenal. So thank you so much. It was lovely listening to you. We had a lot of senior people who, gave their ideas, their visions, their thought processes. And I would like to thank everybody who actively participated. Well, less questions and more answers at the end of the session. So wonderful. Thank you, Dr. Tufanpati. Even though you joined in late, your inputs were much more than when you joined earlier. So thank you so much, sir. Thank you, Alim. For a change, Alim asked only 2 questions.
Compensation phenomenon.
Thank you, Torin.
Yeah, Alim is looking for a Lucknow model.
So thank you. And let me be very, very honest with all of you. The participation was more than 220 and it was remarkable. We thought it will be around 100. I and Alim were discussing. So even if it's 100, for us, it's a full house. But it crossed everything. And consistently, we had 176 people. Everybody wanted to know what to extract from all these experienced people out there. So thank you so much. Next week, we'll meet again. Thank you, Torin. Thank you to all our dedicated supporters, viewers, our encouragement. Thank you so much. Good night. Have a safe weekend.
And thanks to the chair. They have left because of meeting.
Oh, sorry.
Chairpersons here.
And happy Raksha Bandhan. Thank you so much.
Happy Raksha Bandhan.
Thank you very much.
Thank you, sir. I'll close the meeting from my side.
Okay, thank you, everybody.
Thank you. It was great listening to you.
My wishes and apology because my laptop had to be restarted. और किस में नहीं हुआ.
शायद पानी घुस गया दिख रहा है बैकग्राउंड में.
पानी घुस गया, बारिश हो रहा है ना.
Okay, sir. Good night, sir.
Good night, sir.
Okay, thank you.